We have the valve replacement, trunk-catheter valve, is the evoke valve from Edwards, has been approved in 24. A number of RCTs shown quite improvement in benefits in terms of reduction of symptoms and hospitalization. And of course, we all know that echo is the important gatekeeper of feasibility, and it's very important to identify these patients early. So the flow of my talk today will be patient selection is the key in these procedures. And of course, repair, I think Dr. Satish Govind has already touched upon most of it here on patient selection. And repair is replacement. Of course, we have the TR, we have annuloplasty as well. And the replacement is the evoke valve. The other valve is the Lux valve, which is also available. There are some compassionate cases being done in India with the Lux valve. Evoke is still not available in India. Then we have the palliation, which is the trick valve, and then I will show some case examples of our patients. So basically, it's important to assess the TR, not as a patient as a whole, like the patient's presentation, the right ventricular function. Particularly earlier, if we take up these patients, they do well. And so before irreversible RV failure, RV damage, or end organ damage occurs, this is again the most important step in identifying the right time for intervention. And so the current device landscape, as I mentioned to you, for leaflet repair, I think we have T-tier with us. Tri-clip is also there for Nabot, and we have also the MyClip for the mitral from the Merrill, but which you can also use it for tricuspid cases. And we have the Pascal again from Edwards. And we have the orthotropic, as I mentioned, we have this Evoke and Lux are yet to come to India. And annular rupture, again, cardioband is available, but again, it's not available with us. It's again transcatheter where you put a band and you can constrict and cause annular constriction. And heterotopic, again, this is actually now we were doing some cases in palliation, which when all these devices are not available. Now it is reserved for only when all these are not suitable and when you really want to reduce the symptoms. So repair, when it is repairable, replace when the repair is not possible. So that is the important thing. Palliation only when the anatomy is not suitable for any of these. So patient selection, the most important is severity and the symptoms of patients. So maximal medical therapy, the patient still has symptoms. And then you see, assess the patient whether he has concomitant other valve disease like mitral, where we can go for surgery, then definitely surgery is the option. Suppose you have, it's a secondary TR and you have the repairable anatomy, then I think the anatomy if it is suitable, of course TTR is an option. And if it is not suitable for TTR, then we need the TTR that is being shown to reduce TR, not eliminate TR from torrential TR, you can to moderate TR. 2 grades generally less is considered a success. So if you have severe TR, if you come to mild TR, it's considered a success. And if the patient is not suitable for TR, then you have to check whether replacement is an option. But again, replacement has a lot of concerns, replacement, and of course today we don't have much devices with us. And again, this is a palliative disease. So T-tier is current, I think currently available with us, so many options. So it's important to know that mechanism is, we all know this, it's a transcatheter edge-to-edge repair. So approximate the leaflets, create either a double or a triple orifice so that we reduce the ERO and reduce the TR. So the idea is to importantly identify the dominant jet and to identify, actually also imaging is the key here. Echocardiographer determines the result. You can see this for TTR, the echo operator often determines the result. So it's important to have a echo operator very aligned with the operator so that we can do the procedure today. And for us, we are fortunate to have Dr. Chandrasekhar with us for all these procedures, so we are able to do these procedures successfully. So again, it's important to orient the device perpendicularly. It's like how you button the shirt. If you button the wrong, it's not going to increase the leak. So it's very important to orient the clip exactly perpendicular to the annulus, the leaflets. So coaptation plane. So again, adequate tissue grasp is important. So you have to have adequate tissue grasp, otherwise the clip might again get dislodged. So accepting a good reduction, again complete elimination is not always we anticipate, as I said. And Alfrey is the one who surgical stitch was the one which we have taken for TR. I had some opportunity to go and meet Alfrey and spend some time with him. So these are the general favorable and unfavorable. I think Satish has listed a full list, but generally a coaptation gap less than 7-8 mm and adequate leaflet length A good TE window, again very important because everything is dependent on imaging, so very important. And unfavorable cases, a large gap, severe tethering, or there is a poor leaflets, or if there is also a lead or something like that, poor imaging quality, all these are unfavorable factors. So when you have a lot of unfavorable factors, those patients you can think of a replacement strategy or any other palliative option. So evidence, I think today we have too many studies. A trial study again for TIR showed the benefits even up to 2 years. There has been shown, but there's no reduction in mortality in these trials. They have also only shown benefits in terms of symptomatic benefit and reduction in hospitalization, a TR reduction. So again, there are other trials with Pascal. So again, as I mentioned here, it's not proven to reduce mortality. So the 2025 EAC guidelines as far as transcatheter therapy is concerned, it has been